Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the congenital abnormalities of kidney. To know completely about congenital abnormalities, it is necessary to know about development and anatomy of kidney. Development. A bud from the lower end of the mesonephric duct grows backwards and upwards behind the peritoneum to the lumbar region. The stalk of the bud becomes a ureter and its dilated extremity, the pelvis of kidney. Sometimes the bud is duplicated or the stalk becomes bifurcated, giving rise to congenital anomalies. For 6 weeks to 5 months, the primitive renal pelvis divides repeatedly to form collecting tubules in generations. Each collecting tubule is capped with mesoblast, which becomes the glomerulus and convoluted tubule. First 4 generations persist as cystic structures and degenerate. A solitary cyst of kidney results. The fetal kidney is lobulated, but later the lobules become welded together by the growth of the new cortex beneath the capsule. The parenchyma of each kidney is drained by 7 pairs of calyces, 3 in upper and 2 each in the middle and lower segments. Each of the segments represents an anatomical and physiological unit with its own blood supply. There are sphincters at the junction of the minor and major calyces and at pelvis ureteric junction. Each segment of the calcial system fills before its contents are passed into next chamber. Congenital abnormalities of the kidney. Congenital absence of the kidney. Sometimes there is one functioning kidney revealed by pyelography. At cystoscopy, only one ureteric orifice present. Alternatively, ureter and pelvis are present on the non-functioning side, but the parenchyma is absent. In either case, functioning kidney is hypertrophied. Rarely, a congenitally atrophic kidney is present. Renal ectopia. The growth of the kidney is arrested at some part, usually at the brim of the pelvis. The kidney of the opposite side is present in its normal position. Usually the left kidney is ectopic for unknown reasons. If the ectopic kidney is inflamed, this tender lump frequently causes supreme difficulty in diagnosis. Horseshoe kidney. The most medial subdivisions of the primary mesonephric bud of each side fuse and kidney fails to ascend completely. Adrenal glands developed separately or in their normal position. This condition is more common in males. The bridge joining the lower poles lies in front of 4th lumbar vertebra. Fusion occurs very easily when the embryo is of 40 days. At that time, the 2 masses of mesoblast destined to form the kidneys lie very close together. Rarely upper poles may be fused. Clinical features. Horseshoe kidneys are prone to become diseased. Simple infection, tuberculosis and the calculus formation are common complications. A fixed mass below the umbilicus may suggest a horseshoe kidney. Diagnosis is made by pyelographic data. Characteristic finding is that the lower calyces on each side is reversed in position. In majority of cases, the ureter is curved like a flower vase. It is not a contraindication for pregnancy. Urinary complications are frequent. Treatment. When there is a pair of a non-specific infection is there, division of isthmus is usually curative. The operation can be performed extraperitoneally, but a transperitoneal approach gives a much better view of renal arteries and veins and is easier to decide whether nephropexy is desirable. The area can be drained extraperitoneally if one half of a horseshoe kidney is irreparable, like calculus or neoplasm. Heminephrectomy is performed, provided the remaining half has adequate function. Unilateral fusion, crossed dystrophia. Both kidneys are present in one line. One kidney carrying its own blood vessels and the ureter opening into the bladder in a normal position. Crosses the midline and its upper pole fuses with the lower pole of the normally placed kidney. In this instance, both pelvises are situated one above the other, medial to the renal parenchyma. Unilateral long kidney. In some cases, the pelvis of the crossed kidney faces laterally. S-shaped kidney. Congenital cystic kidney, otherwise called polycystic kidney. The disease is hereditary and may be transmitted by either parent. In some cases, there is also congenital cystic liver or pancreas may be there. The organs are elongated. Surface gives an appearance of bubbles. The section shows cysts of varying size, some containing clear fluid, other thick brown material, and some coagulated blood. Clinical features. In the fetus, the kidney may be so large to obstruct labor. Some are stillbirths and the other die shortly after birth. In the infant, in case of congenital cystic kidney during this period, renal rickets often develops a few years before the uremia. Between 3 and 30 years, there may be encountered rarely. In adults, this condition is common in women. Renal enlargement. It is large, knobby. Sometimes congenital cystic kidneys are revealed only at laparotomy for some other condition. Unilateral renal swelling. One kidney containing large cysts than the other, and the physical signs are those of renal neoplasm. The patient with congenital cystic kidney passes abundant urine of low specific gravity containing a trace of albumin but no casts, no cells. On cystoscopy, there is often considerable delay in excretion of indigo-caramine, even in cases with a normal or slightly elevated blood urea. Pain. Pain is due to the weight of the organ dragging upon its pedicle or to tension within the cyst. Often the pain is a dull ache in the loin. Sometimes it takes the form of renal colic. Here the calculus is suspect. Hematuria. As a result of over-distension, one of the cysts ruptures into the renal pelvis and causes hematuria. It may last for a few days and recurs at intervals. Sometimes it may be profuse. Infection. The most common complication is the pyelonephritis hypertension. Majority of the patients with congenital cystic kidney above the age of 20 is hypertension. Uremia. There may be anorexia, headache, gastric symptoms. He is usually given some placebo till persistent symptoms appear, followed by drowsiness and vomiting. Signs of uremia may often commence suddenly and few may survive. severe anemia is common. Pylography. Excretory pylography is the best way for confirming diagnosis. Sometimes retrograde pylography may be needed. Only one side should be injected. The shadow of the kidneys are enlarged in all directions. The calyces are stretched over the cysts and are often narrow like legs of spider or bell-like. Treatment. Expectant. The patient has to drink large quantity of water, have a low protein diet, take iron to prevent anemia. Infection, which is common, should be treated promptly. Operation. By relieving the pressure on the remaining real parenchyma, resolving the operation, if performed early, improves renal function. In many cases, life is prolonged for more than 5 years. Reusing's operation. First one kidney and then the other is exposed. The cysts are incised with a narrow bladder scalpel, first on convex border, then on posterior surface, and finally, as the kidney becomes more manageable in size, the peritoneum is peeled away and the anterior surface is dealt with similarly. Solitary renal cyst. It may arise in the same way but the smaller scale. It may also arise from bygone trauma or infection causing blockage of tubule. Clinical features. There may be no pathognomonic symptoms or no symptoms till the swelling is noticed, or there may be dull pain in the loin. The cyst can be infected, and if a swelling is palpable and particularly if the swelling is tender, possible diagnosis is pyelonephrosis. Spontaneous hemorrhage into the cyst occurs from time to time. In that case, sudden real pain may be there. Occasionally, the cyst may press the pelvic ureteric junction and causes urinary symptoms. Radiology. Pylography reveals a filling defect of one or more calyces, simulating the deformity produced by a neoplasm, but typically rounded. It is possible to distinguish a renal cyst from renal neoplasm by selective renal arteriography. Treatment. In every case, exploration is advised. Renal cysts can be caused by a tumor blocking tubules and interfering with the vascular supply to the same area of the kidney. Having displayed the kidney, the operation is varied according to the circumstances. Kirwan's method. If the cyst is blue domed and aspiration reveals clear fluid and the portion of the cyst wall lying above the surface is excised, the remaining portion of the cyst is swabbed with the phenol in glycerin equal parts, followed by the application of 95% alcohol. The cavity is filled with the perinephric fat and the edges of the cavity are approximated. The phenol destroys the lining membrane. Partial nephrectomy. Partial nephrectomy is performed if contents of the sac are blood-stained, which may contain papilliferous neoplasm. Nephrectomy. Nephrectomy is performed if there are indications that the cyst is a malignant degeneration of a neoplasm, like irregular induration at the periphery of the cyst. Aberrant renal vessels. These are found on left side than on right side. In females, it is more unilateral or more than bilateral. Usually, the aberrant artery is small. Occasionally, it is large, supplying the quarter of the renal parenchyma. Division will cause infarction of the corresponding renal tissue. On the other hand, an obstructing aberrant renal vein can be divided with impunity, as the venous collateral circulation is very generous. That's all about the congenital abnormalities of the kidney, and in the next video I will discuss about some other disease. Thank you.